Local anesthetic applied. What is the definition of regional anesthesia? Local anesthetic applied around the peripheral nerve at any point along the length of the nerve, reducing or preventing impulse transmission. The advantages is there is no CNS depression, patient is conscious. Regional anesthesia techniques categorized as follows: spinal, epidural, and peripheral nerve blocks. The main advantage is we are giving local anesthesia drugs to the particular nerve, so that only that the area that is supplied by the nerve is only anesthetized. Rest of the body is not affected by the anesthesia drugs. Next slide. So we'll go individually. What is what? Spinal anesthesia is the injection of small amounts of local anesthetics into CSF at the level of L2 vertebra, where the spinal cord ends. Anesthesia of the lower body part below the umbilicus is achieved with spinal anesthesia. Next slide. Next slide. So you can see in the lumbar area, you can see the spinal space. The green color is the subarachnoid space. That is the point where the drug is injected in spinal anesthesia. The violet color is the epidural space. That's where the epidural drug, epidural space. Even catheters are passed through the epidural space, but spinal, we rarely pass through the catheters, and the volume of the drug is low. Next slide. So you can see the positions for the spinal and epidural blocks. Either the patient, both the blocks can be performed in either sitting or lateral positions, whichever is comfortable to the patient. At the level of L3 and L4, spinal anesthesia is given mostly below the L2 vertebra, because the spinal cord, to reduce the injury to the injury to the spinal cord. Epidural anesthesia can be given all the way from cervical spine to lumbar spine. Next slide. So you can see once the needle is inserted, spinal needle is inserted, we should see a clear flow of CSF coming from the needle, and then your drug is injected. The drug which is there in the 5 ml of the syringe, that can be injected into the subarachnoid space. Next slide. So these are the equipment mainly used for epidural and spinal anesthesia. You can clearly see the spinal needles, and the orange color is the 25 gauge spinal needle, and the other thing is the 5 cc blue color one is the epidural needle. It is called Tuhaye epidural needle, and that is the air syringe which they give. And down one, what you are seeing is the epidural catheter. Next slide. So this is how the epidural was inserted. Once the epidural is in space, the identification of the epidural space is done by loss of resistance technique. Through that, we'll induce a catheter. We'll put a catheter through that, and the catheter is inserted into the epidural space, and then drug is injected into the catheter. Next slide. So what is the difference between spinal and epidural? Spinal is given below L1 and L2, where spinal cord ends. Epidural or extradural given at the level, any level in the vertebral column. Subarachnoid space is the target area in spinal anesthesia. Epidural space between ligamentum trem and dura mater is the target area in epidural anesthesia. Identification when CSF is clearly appear. Backflows of CSF is the indication that needle is in the subarachnoid space, and it is epidural space is identified by loss of resistance technique. Only main basic differences is the dosing of the drug. Only 2.5 to 3.5 ml of your local anesthetic is required for spinal anesthesia, whereas 15 to 20 ml is required for epidural anesthesia. Onset of action is very rapid in spinal, and it will take 15 to 20 minutes in epidural. And more dense block can be observed in spinal anesthesia, as you are directly blocking the nerves. Next. So what are all the complications because of epidural and spinal anesthesia? Related to needle insertion, they can be postdural puncture headache, block failure, permanent injury from nerve damage, backache, spinal hematoma, meningitis, exaggerated physical response. So any spinal anesthesia, when you give spinal anesthesia, there is a physiological response that patient will develop hypotension, bradycardia, that is expected. That should not go beyond a certain level. You should allow the BP to fall 30% of the baseline. So whatever is the initial normal BP, after giving the injection, the BP should fall only 30% less or 30% more. So if it is falling, it should fall within 30%. If it is falling more than 30%, then you have to act and treat the patient. So hypotension and bradycardia are the two most common symptoms immediately which happen after spinal anesthesia. Then shivering, high block, urinary retention, cardiac arrest, Related to drugs, pruritus, nausea, vomiting, and systemic toxicity. All these are side effects of your opioids, which are giving during neuraxial blockade. Next slide. So coming to the peripheral nerve blocks, you can see where all the circles, the red circles are, wherever the nerves can be blocked. You can say brachial plexus is the main block which is used for upper limb extremity. So you can block the brachial plexus at supraclavicular level, interscalene level, and infraclavicular level, axillary block and midhumeral block. Forearm blocks like median and ulnar nerve blocks can be done for upper limb. For lower limb, it will be lumbar plexus, femoral nerve block, adductor canal block, proximal sciatic blocks, and popliteal and ankle block. Next slide. So again, peripheral nerve blockage is done by, you can have many options how to do a block. You can use an ultrasound as shown in the figure. It is indicated for arm, elbow, forearm, and hand surgery, the brachial plexus. Again, you can also perform this block blindly. You should know perfect anatomy and you should have adequate training while performing these blocks blindly, either with ultrasound or using a peripheral nerve stimulator. Next slide. So this is a blind performance of an ankle block where you can have patient can perform the if this block is given, the surgery can be done in the fingers. Any toe gangrenous amputation of the toes, all these things can be done while giving a good ankle block blindly. But you should have a thorough knowledge of the anatomy of the nerves which you are going to get blocked. Next slide. So what are the potential complications of giving a peripheral nerve blockade? It's like block failure, intravascular injection, local anesthetic toxicity. You should know the signs and symptoms of local anesthetic toxicity, nerve damage, injury secondary to numbness or weakness, and infection. Next slide. So another new concept is, which is very new to the modern day anesthesia practice, is TIVA. TIVA is total intravenous anesthesia. That means we will not use any muscle relaxants, or we may use muscle relaxant, but we will not use any inhalation anesthetic agent, so that the cut down of greenhouse gases, air pollution, theater pollution, all will come down. It is basically used to give general anesthesia. It is given through intravenous lines, which uses combination of agents given exclusively by the intravenous route with the use of inhalation agents, including nitrous oxide, but oxygen, compressed air, or helium are exception. TIVA is used in induction as well as in maintenance of anesthesia. Next slide. Again, coming to sedation, there are three levels: mild, moderate, and deep. Sedation is a relaxed state or temporary decrease in level of consciousness. The mild sedation is relaxed, patient is relaxed, but patient is awake, can respond to verbal commands. Moderate is sleepy, but can awake by respond to verbal or tactile stimuli. Deep sedation is deep sleep and cannot be easily aroused, merely unconscious. Okay, next slide. So all the time during the my regional anesthesia talks, I'm talking about local anesthetics. You should be wondering what are local anesthetic drugs. So local anesthetics can be classified into, there are two groups of drugs: amide class and ester class. Amide class includes lignocaine, prilocaine, bupivacaine, dibukane, mepivacaine, etidocaine, ropivacaine. Ester class: cocaine, procaine, chlorprocaine, tetracaine, benzocaine. Most commonly used in anesthesia practice are lignocaine, bupivacaine, and ropivacaine, along with chlorprocaine. Okay, next slide. So when it comes to anesthetizing the patients, it's not only about the giving the anesthesia. You have to monitor the properly monitor the patient. So when for routine surgeries, we need a common basic monitoring. For advanced higher end surgeries, we may need go for advanced monitoring. So this is the basic monitor which we use routinely for our regular anesthesia practice. You can see the ECG, you can see the SpO2 saturation, you can see the heart rate, you can see the sawtooth, the waveform, which is called CO2. It is called end-tidal CO2 concentration. It is given in kilopascals. So we need to monitor. These are the minimum monitoring standards according to American Society of Anesthesiologists, minimum monitoring standards for giving general anesthesia. You need an ECG, you need an SpO2, you need a temperature, you need a NIB pickup, you need a gas monitoring. All these things are there in the monitor. Next slide. So when it comes to advanced things, we even monitor intravenous, intra-arterial pressure. We need a non-invasive HB. We can see the temperature. This is the advanced monitoring used for higher end surgeries. Okay, thank you.